Our next session is a collaborative society guidelines, a look at this scenario, and our moderator for this session is Dr. Sebastian Schubl. He's trauma critical care surgeon from University of California, Irvine campus, and the village idiot.
I am totally putting that on my resume. Good morning, everybody. So I think that probably everybody in this room is a member of more than one society. And actually one of the things I love is that interaction between the people that I meet at the SIS and the people that are here, or East and the SIS, and whatever those interconnections can be. So this work goes back, this work reflects relationships between CWIS and the two other organizations that I like to spend my time on when I'm not spending my time on here, East and the Surgical Infection Society. And I'm incredibly proud that the two people who are here to teach us about what they learned are experts in this field, and they dedicated an enormous amount of time to have these practice management guidelines created. I also want to just say that, particularly for the younger members that are here today, let this not be the last of these sessions. Whatever organization you are engaged in outside of this one, there is an overlap. Find it and see if you can create something along these lines. I'd love to have a panel next year with 5 of these, maybe in a few years, even more. So with that, I'd like to invite up our first speaker, my good friend, Kaushik Mukherjee from Loma Linda University. He's going to talk to us about the practice management guideline that we did with East.
Thanks, everybody. My membership check is in the mail. I'm really pleased to be here. It's my first time at this meeting, and it's been a blast so far. Let me start by telling you a little bit about why guidelines. I was really surprised when my trauma program manager told me we've got our re-verification coming up, that we had created 23 new guidelines just for Loma Linda in the past 18 months or so. And that's an awesome way to get everyone in your group practicing on the same page. And on a broader level, it's a great way to synthesize the literature. In Dr. K's address, the Tanaka paper itself did not revolutionize how we take care of patients, but it's that sum total of all the literature that creates an overwhelming desire to do things differently. And the guideline is the manifestation of that. And the great thing about these guidelines is we can actually apply them very easily at our own institution and say, hey, this is the East CWIS guideline. This is how it's recommended we do things, get buy-in very quickly, and then get everyone on the same page. So I'm going to talk about non-surgical management. And again, why non-surgical management? We know we all like to fix rib fractures. We have good literature to justify that practice. But that's still just one part of the overall management of the patient. We've got to control their pain. We've got to make sure they don't decompensate from a pneumonia. And we have to take care of those occasional patients that are, for whatever reason, not a surgical candidate or choose not to be a surgical candidate. And they still need to get care as well. So could I get the next slide, please? And you see from the list of names and authors, a tremendous amount of work went into this. And I'm very grateful for all the CWIS members that were participants here. Nothing to disclose. Next slide, please. So chest wall injury, I can advance them on my own, ha ha ha. So chest wall injury is obviously a significant source of morbidity and mortality, otherwise none of us would all be here. And this effect is magnified in our geriatric population. We were tasked with looking at both the non-op and operative management of rib fractures. Obviously that was way too big to put in one paper. So the operative paper is coming maybe next year. But in the meantime, we focused on some key non-operative topics. This was a huge task. We've been doing this for like, 18 months or so, just about ready to submit to the Journal of Trauma. So this is our literature search process. We started with, what's up there, 9,000 initial papers, filtered down to 151 that covered both operative and non-op. And then actually we completed the non-op part of the project, and then we actually went back and got more papers for the operative part of the project, so that's why that's coming second. And that includes some of the papers that came out from the CWIS special version of the Journal of Trauma. So we looked at a total of 6 PICO questions, and I'll break down those PICO questions and the relevant data. So the first one basically is 4 patients above the age of 65 with at least 3 rib fractures. Should we put them all in an ICU? And should we do that to reduce pneumonia, need for intubation, ventilator days, or mortality? So, as you might imagine, no one gets randomized to ICU or floor, like ever, right? So this is all retrospective data. And what a lot of it came down to is looking at different risk factors for bad outcomes, including poor performance on incentive spirometry, poor functional status, as exemplified by higher age, above 72, or using a walker, higher injury severity score, and again, higher median age. So these are all kind of higher risk patients. But the overall quality of the evidence was very low because it was all retrospective. We didn't have a recommendation here that was any better than clinical judgment, because we kind of all know there's a lot of frailty systems out there that help you determine who's the frail patient and who's not. But what it comes down to, that individual clinician judgment is sometimes going to say, I want to put this guy in the ICU because I'm worried about him or her decompensating. And we couldn't really find anything better than that that says you should put all of these patients in the ICU and put all of these patients on the floor. I can say that personally I would consider, and I'm telling my colleagues to consider, ICU admission for patients with more severe chest injuries, the older or particularly the frail patients, and we're using the MFI-5 to help determine that at our institution. Poor aeration in a pulmonary toilet, and incentive spirometry. And I'm going to talk about incentive spirometry next. Should we use incentive spirometry to reduce pneumonia, risk for intubation, or mortality? And this may strike you as a, well, why not? And that's certainly part of what we were thinking about, but there actually are papers written about incentive spirometry, which is really cool. So Dr. Kelly used incentive spirometry to guide which patients he was going to put on a non-invasive positive pressure ventilation protocol. And that protocol helped reduce intubation and unplanned ICU admissions in a pretty sick cohort of patients. Dr. Sadler found that patients with less than 1 liter on their incentive spirometry have a higher risk of pulmonary complications, kind of validating what we've already seen in a lot of our practices. And what we basically found is, again, this is retrospective. No one gets, very few people, if anything, get randomized to IS or not IS, because we all tend to use it. But when you study it, you find that there's not a lot of harm, it's relatively cheap, there's no side effects, and it potentially has some benefit. So we recommended that people use it. And at the very end, I'll put up a slide that shows how, at least I recommend we're using it at our institution, and how it can kind of form a part of your treatment for chest wall injury patients. Third topic was non-invasive positive pressure ventilation in patients who fail therapy with nasal cannula or face mask, versus going straight to endotracheal intubation and positive pressure ventilation. And will that reduce the rate of pneumonia, intubation, ventilator days, or mortality? So, sorry, the forest plot. This is the bane of existence for every meta-analyzer and literature reviewer. But what you see here is there's not that many randomized controlled studies on this, okay? But the 2 that are in existence do show that if you use non-invasive positive pressure ventilation, there is a reduction in mortality and a reduction in the rate of pneumonia. And it's statistically significant, which is definitely a cool thing to find out. Delving in some of these studies a little bit further, in the Bolliger study, everyone got an epidural, so that's a little bit of a complicating factor. It's a little bit a younger patient population, And again, the same thing in the Gunda's randomized trial, the younger patients. So there's a little bit of an indirect effect. It's not necessarily just older patients. The Hernandez trial, I couldn't put in the meta-analysis because the groups were different, but it's actually the most like what we'd actually do in practice. They randomized one group to face mask and one group to non-invasive positive pressure ventilation. 40% of the face mask patients got intubated, only 12% of the non-invasive positive pressure ventilation group got intubated, and that was a statistically significant finding. So the other two studies randomized people to either upfront intubation or NIPPV first and then intubation if you fail, which is not something that we typically do now, right? Because we will make people demonstrate that they're failing before we proceed with intubation. So the two randomized controlled trials, Bolliger and Gunda's, both had good treatment effects, both in younger patients, and then the Hernandez trial really simulates what I would do in regular practice. The key part here why we didn't go like full throttle on this is because you have to be careful who you put on NIPPV, obviously. There's people who can't protect their airway. There's a significant portion of our patients that have head injuries or are altered, and those are not necessarily safe to put a BiPAP mask on. So because of that, we did not do a full recommendation saying this should be the standard of care. We were saying that we should suggest use of NIPPV after we verified that those patients have failed kind of standard stuff and we're sure they can protect their airway so we don't have a bad outcome from aspiration. Fourth question, and this gets into the interesting / more controversial findings in our paper, ketamine. So should we use ketamine for patients to reduce pain, pneumonia, need for intubation, ventilator days, or mortality as part of a structured multimodal pain therapy regimen? So if you look at pain, there were two studies, and strangely enough, these were done by the same group of investigators, and one study was in 64 and younger, and one study was in 65 and older. So it's kind of interesting. But there was also a retrospective case control study demonstrating some lower pain scores with ketamine. And as I mentioned, both RCTs are by the same group. There may be some evidence for reduction in morphine equivalence, so that's probably a good secondary outcome. I mean, I'm not saying not to use ketamine, but we didn't find overwhelming evidence that it's a super awesome painkiller that should be used for everybody. And hence, we didn't have a recommendation for that ketamine should be, kind of the standard of care. And when we say recommendation, we really mean that this should be the standard of care, and I probably should have been upfront about that. And when we say suggest, it's something to consider, something that may be beneficial, but not necessarily the force of standard of care. So we take that full recommendation pretty seriously. So before I get into the epidurals and locoregional blocks, so a lot of the studies on this topic are now 20 years old, and because they're 20 years old, we've learned a lot about multimodal pain control in the past 20 years. So for example, the Bulger paper from 2000, only 38% of the patients got Tylenol, 14% received Toradol, and they didn't look at the number of patients who got things like gabapentin or Lyrica or other medications like that. A lot of studies could not be meta-analyzed. There's a lot of incomplete crossover studies. There's a lot of studies comparing different realms of locoregional pain control, randomizing to epidural or locoregional block, like a serratus anterior block or something like that, but not really comparing those specifically to not doing them. And so it makes looking at the data very problematic because every group, every study had a slightly different protocol for what the control group was. So there's probably a good reason to do this study again, a good, well-randomized, well-controlled study of epidural therapy in the modern era with good multimodal pain control. And I think that's the overall message of this for those of you who are epidural fans. So in this group, should we recommend that epidurals be used to reduce pain, pneumonia, need for intubation, hospital length of stay, or mortality? So there was a lot of retrospective data. And actually, when you look at it, none of it is really that positive. The need for intubation was higher in the epidural group. When you meta-analyze everything, the risk for pneumonia was a wash. The risk for mortality was a wash. And hospital length of stay did not favor the epidural group, which makes me wonder about selection bias, because are we just putting epidurals in sicker patients retrospectively? And then finally, this is ventilator days, also a wash. You can also see that the different studies also are all over the map. So some are finding positive outcomes, some are finding negative outcomes. Prospectively, there were some randomized controlled data that we could meta-analyze, and that showed that there was a trend towards improvement with pneumonia, but it just fell short of statistical significance. And mortality was pretty clearly like in the middle, so not really a benefit there. Hospital length of stay, again, a trend towards significance, but you have two studies on one side and one that's strongly favorable. Ventilator days, again, a trend towards significance, but not quite there. So this was very controversial. So we had 19 authors, 11 were straight in the middle and said we can't recommend for or against. Some people were saying, well, let's do a suggestion. Some people were like, well, suggest against it. One person was full on recommend against it, this guy. And we ended up, this is a problem when you get 19 people, in a virtual Zoom and they don't all agree. So we have to disclose that. We have to say it's a non-unanimous recommendation or non-unanimous group. And then to make things more complicated, we had a previous East guideline that was pro-epidural, that recommended epidural use. And that included some papers that we didn't include in this review. One was a conference abstract that never got published, and one was a study that only showed reduction in numeric pain scores, but not any of the other outcomes. So we still didn't feel that that was enough to say this should be the standard of care. So that was our take on epidurals. And I think the message is that we need to restudy epidurals in the modern era with better non-invasive pain control. Last question we looked at was non-epidural locoregional anesthetics like local blocks, subcutaneous infusion pumps, same outcomes. Pneumonia, no real clear benefit. Two randomized controlled trials that were directly opposite outcomes. And again, a controversial discussion, but once we kind of made that decision for epidurals, it was going to be pretty similar for non-epidural locoregional anesthesia. And I think for those of you who are, investigators in this room, this is another great potential area to do a well-controlled randomized trial and see if we can find better data. In summary, our conclusions were no recommendation for or against ICU admission as a general rule, although we can identify some subsets that may be at higher risk. We do recommend routine use of incentive spirometry. We suggest that we try a non-invasive positive pressure ventilation rather than endotracheal intubation up front when patients fail initial management. No recommendations on ketamine, no recommendations on thoracic epidural, no recommendations on non-epidural locoregional anesthetics. And then finally, this is how I, kind of translated all that stuff into when I presented to my group and said, this is how I think we should manage rib fractures non-operatively. We just have to start by controlling pain. Some people have a very robust acute pain service at their institution, and they'll throw an epidural in right quick and do really good management. To be honest, I don't. It's hard to get an epidural at Loma Linda. It's hard to get a serratus block at Loma Linda. But I think different institutions have different strengths and weaknesses in this area, so everyone should do whatever we can up front to control pain, check incentive spirometry, and then see how people are doing. If they're not doing well, they may have to go to the ICU. If they continue to have respiratory failure, it may be worthwhile to try non-invasive positive pressure ventilation rather than upfront endotracheal intubation. So Again, I want to thank the Chest Wall Injury Society. This was a great collaborative effort between CWIS and East, and I hope that we can have more of these going forward. And I'm looking to see where I can sign up to become a CWIS Collaborative Chest Injury Center. So let me know, where the sheet is, okay? So thanks, and I'm happy to take any questions if we have time.
Zach Bowman, UNMC. Thank you so much for this. I was participating in this, and obviously it was a huge undertaking, but I think a fantastic undertaking between two organizations. Just out of curiosity, have we reached out to any of the anesthesia organizations yet and let them know that we're going to be, publishing this? It's probably going to change their practice a little bit, and they, are probably going to have some comments about it as well. So I was just curious as to if we've gone those next steps yet.
I haven't actually. That's a really good idea. We probably should.
Near us, Palm Beach. Any,
There's a line near.
I didn't see it.
Yeah.
I didn't look behind me. On affirmative, any data, anything about affirmative? You kind of neglected that one. In our hospital, it was taken off. Tylenol IV. Help, not help, useless.
Sorry, I didn't.
You're talking about IV Tylenol? I don't think we follow your question.
Oh, for MEP, okay. Yeah, we didn't have a specific question about that. I know a lot of folks are using it. We're using it as well. Due to cost, it's restricted for 24 hours at my hospital, but we didn't specifically study it as part of this, but I think it's a good component of multimodal pain control and relatively benign.
And just lastly, so all this is just good for a few days. What about the long run, non-operative management?
Right, so that's the next paper, and hopefully, if you guys are willing, I think it should be done in time to pencil in to discuss next year, but I think that's the next thing that we're kind of, we did some of that work and then actually got more papers and are going to go back and look at all those papers, so that's to come, TBD.
So we have two more questions from the back mic and then one from the front. Fred, if you don't mind waiting for a second.
Not at all.
Hey, good morning. Good to see a bunch of familiar faces in the audience. Nice to see everybody. Alexander Colonna from Salt Lake City. When you were looking at the guidelines, any utility in using formal PFT testing to help guide this? There's that paper from the Las Vegas group a couple of years ago that incorporated into their protocols, but I haven't seen much since then. I think that was 2017 or 2018 when that paper came out.
Yeah, good question. So I think it's one of those things that some hospitals have good facilities to do PFTs on inpatients and some hospitals don't. I think it can be a really good adjunct, and in fact, some of the papers we looked at, specifically dealing with incentive spirometry, also measured PFTs as a corollary. I didn't really talk about that, but did mention that folks with low IS also had poor performance on PFTs. I think it's one of those things that if you have that resource, it absolutely would be beneficial to use, but a lot of us don't, and that makes incentive spirometry the kind of the surrogate for it, that relatively attractive to use because it does correlate and it seems to sort out the higher risk patients.
Peter Cole, Minnesota. I found it interesting that the results of the thoracic epidural are not non-conclusive or conflicting with regard to their efficacy and management based on those outcome variables. My question is, what do we know about the impact on motor function of the epidural, thoracic epidural, and does that negative impact take away the advantages of pain control itself, and are there ways to mitigate that with the agents that are used?
That's a great question. It's probably something I'd have to punt to an anesthesiologist as far as the details of the medications, but I can say anecdotally, I think my nurses at least are much less likely to get an epidural patient out of bed than they are a non-epidural patient out of bed. I think there's a lot of fear and concern that that catheter will get dislodged or have a problem or they'll trip over it. And so I think there's a part of it as well, and I'm really glad we had that session about the physical therapy, because that's such a critical part of this. And so from my part, I find it concerning when I round on the same person with the epidural day after day, and they're always in bed. And so I think that's an important piece to consider as well. Dr. Parachi.
Yeah, Fred Pirachi, Denver. This is a tremendous amount of work. Thank you. I was looking at the recommendation slide at the end, and I see no recommendation on ketamine, none on epidural, none on local regional. I worry a little bit that people might misinterpret this as, let's just give more opioids. So how do we balance communicating that there's no conclusive evidence on multimodal, specifically local regional, with sticking with multimodal and not promoting opioid use?
That's a great point, and I think that comes down to how we write the paper and how we phrase the questions. If you noticed, all of our PICO questions have as the comparator group multimodal pain therapy or pain management therapy, and I think that's an important piece to put in the discussion and how to use these guidelines, and in fact, I'm going to do that. I think I'm going to emphasize that we not just return to just using opioids, because I think that's really critical. Thank you.
I've got one more for you. Before I ask it though, while there were 19 authors on this paper, 90% of the work was done by this man right here. And it was insane how much time you dedicated to this effort. And I think it's incredible, and we should all be incredibly thankful. And there's another one coming, because this is the non-op one, and now he's doing the operative one. So look out for that. My question is this. I actually have started using the existence of an epidural when one slides past me and I can't block it as an indication to take a patient to the operating room, because you can't go home with an epidural. So what I want to ask you is, how can you design a study when the answer might be not epidural versus non-epidural local regional multimodal pain therapy, but anyone that would probably benefit from the epidural would simultaneously benefit from rib stabilization? Do you accept that within your cohort? Do you carve those patients out? And do you think that the status of the literature today, is that even allowable to not have SSRF patients in that group? And if you put them in, how are you ever going to have one-to-one comparators?
Yeah, that's a really tough question. I think the real question is that, as I pointed out in the beginning, no one manages patients non-operatively, or I would say very few. I think there's still a spectrum in terms of how aggressive people are with rib plating, but this does not exist in isolation, and that's what makes it so complex. So I think kind of the plan from East is to actually generate 3 papers. One is this, one is the operative management, and the third is a clinical practice guideline that's kind of more going off the evidence, less forest plots and stuff, but really going off of, well, how do you manage these patients along the continuum of their care, right? And that's the thing I struggled with when I was making my institutional protocol. Do you put an epidural in until you get them to the operating room? Do you not put an epidural in at all? And sometimes you find that the anesthesiologists are willing to do the epidurals in the 3rd floor, but not, where your OR is, but not so much on the 14th and 15th floor where your patient is. And I found a lot of that too. So I think it's really hard to design that kind of study, and might have to use parallel tracks, definitely something multi-center to get enough patients, but it's extraordinarily complex. I think this is it's a good study though, it's a good idea, and maybe it's something to, consider doing out of CWIS, out of all the collaborative centers, to really tease out, which patients are going to be the epidural ones. And then the other piece of it is the same patients who might refuse surgery might also refuse to be in your paper. And that creates a problem too, right? Because then you have bias in terms of the number of patients and the types of patients that you're working with. So yeah, I don't have any quick answers for that, but I'm happy to sit in a room with folks and help figure it out.
Maybe that's what we need to do. All right, thank you, Doctor.
Thank you.
Next, we have Dr. Joseph Forrester from Stanford University.
All right. Well, thank you for the privilege of the podium. I'll be discussing the SIS and CWIS guidelines that will be actually released this coming June as the lead article in surgical infections. So I have several financial disclosures, neither of or none of which are relevant to this talk. So rib fractures are common injuries worldwide, with nearly 500,000 rib fracture-associated ED visits per year in the United States alone. Fractures result in acute morbidity, mortality, chronic pain, and prolonged disability. Surgical stabilization of rib fractures, abbreviated SSRF, or sternal fractures, SSSF, are recommended therapeutic modalities for patients with flail chest or multiple displaced fractures with physiologic compromise. Surgical stabilization involves open reduction and internal fixation of the fractures with a plate and screw construct, and most plates are composed of titanium, although absorbable plates do exist. Now, presence of this foreign, non-absorbable implanted material creates an opportunity for the development of implant-related infections. While thankfully, implant infection rates remain low in described series, management of these infections can be challenging and have been treated with prolonged antibiotic therapy, implant removal, or both. Additionally, on top of the original trauma, patients undergoing SSRF may have concomitant infectious processes like sepsis, pneumonia, or sources of contamination like an open chest wound. However, there is little published literature providing guidance to surgeons performing SSRF or SSSF on choice or duration or route of antibiotic therapy in these commonly encountered situations. So to begin to address this knowledge gap, the Surgical Infection Society's Therapeutics and Guidelines Committee convened with the Chest Wall Injury Society's Publication Committee to develop pragmatic recommendations for surgeons performing these surgeries to minimize implant-related infections. We established 4 clinical questions. First, in adult patients undergoing SSRF or SSSF, what is the optimal duration and route of antibiotics to minimize risk of implant-related infections? We then applied the basic format of clinical question number 1 to 3 commonly encountered scenarios: patients with concomitant sepsis or pneumonia, patients with an empyema, and lastly, patients with an open or contaminated chest wall injury. We searched PubMed, Embase, Web of Science, and Cochrane for the following terms alone and in combination, and applied the below criteria. 3,073 studies were initially identified. After removing duplicates, abstract screening, and full text review, we used 10 studies to inform our clinical questions. Additionally, we used 12 non-SIS or CWIS society guidelines, systematic reviews, meta-analyses, or applicable studies, peripherally applicable to the clinical questions, to help inform recommendations in the form of a narrative review. So for the first clinical question, we identified 4 studies that included specific information about route and duration of antibiotic administration. There were 3 retrospective observational studies and 1 prospective observational study. 3 of the 4 studies were single institution. These 4 studies comprised 1,022 patients. All patients in these 4 studies received antibiotics with gram-positive coverage within 30 minutes of incision, and only 4 patients, or 0.4% of the population, ultimately required implant removal. Now, there were 4 additional studies we included in our narrative review. The takeaway points from these supportive guidelines are that perioperative antibiotics should be administered within 30 minutes of the incision, antibiotics should have gram-positive organism coverage, that no additional prophylactic antibiotics are indicated after the surgical incision is closed, and there is no indication for topical antibiotics and no need to soak implants. This led our working group to provide the following recommendation: that there was insufficient evidence to suspect that the existing prophylactic perioperative guidelines already in existence are inadequate for patients undergoing SSRF or SSSF, barring presence of other infectious processes. Now, for the second clinical question, patients undergoing stabilization with concomitant sepsis or pneumonia, we identified 3 studies that included specific information about route, choice, and duration of antibiotics. 2 were retrospective observational studies, and 1 was a case report. All 3 studies were single institution and comprised 31 patients undergoing SSRF or SSSF with sepsis or pneumonia. None of these patients ultimately required implant removal. Now, there were 3 additional studies we included in our narrative review. The takeaway points from these 3 manuscripts included that MRSA bacteremia may require 6 weeks of therapy, MRSA pneumonia may require a 7 to 21-day course of therapy, hospital or ventilator-associated pneumonia from other common pathogens can be treated with a 7-day course of therapy, and gram-negative bacteremia may be treated with a 7-day course of antibiotics. Recommendation of antibiotics based on anticipated organism are presented in each of the reference guidelines. This led our working group to provide the following recommendation, that antibiotics, the choice, the route, and the duration should be directed according to the existing recommendations for management of sepsis or pneumonia, not SSRF or SSSF, with the caveat that this literature base does not directly address patients with chest wall injury. Now, for clinical question number 3, patients with concomitant empyema, we identified 3 studies that included information about route and duration of antibiotic administration. 2 are case reports, and 1 was a case series, all were single institution. In total, 24 patients with an empyema were included, none of which required implant removal. Now, there were 2 additional studies we included in our narrative review. The takeaway points from these 2 documents included the importance of drainage in patients with an empyema, use of muscle flaps preferentially to fill potential spaces caused by the empyema, treatment with 2 to 6 weeks of antibiotics after appropriate drainage, and if antibiotic beads are placed to fill potential spaces, that PMMA beads have the most supportive data, but that biodegradable ceramic beads may present another option combined with tailored antibiotic therapy. This led our working group to provide the following recommendation. Leaning on the AATS and AO guidelines, we recommended that antibiotic choice, route, and duration may be directed according to existing recommendations for management of an empyema and orthopedic operations in infected fields. Now, for clinical question number 4, patients undergoing SSRF or SSSF with an open or contaminated chest wound, we identified 3 studies that included information about route, choice, and duration of antibiotic administration in this patient cohort. 2 were retrospective observational studies, and 1 was a case series. All were single institution, and in total, 34 patients with an open or contaminated chest wall wound were included, none of which required implant removal. Now, there were 6 additional studies that we included in our narrative review. There are several takeaway points from these documents. In patients with open fractures of the extremities, which we then extrapolated to chest wall injury, systemic antibiotics with gram-positive coverage should be started early and continued up to 72 hours or 24 hours after open fracture coverage, whichever comes first. Patients with MRSA cellulitis that is present concomitantly should be treated with a 7 to 14-day course of antibiotics, and that muscle flaps are preferable for coverage of soft tissue defects, and as with an empyema, if beads are placed, most data supports PMMA beads. This led our working group to provide the following recommendation, that antibiotic choice, route, and duration be directed according to the existing recommendations for open long bone fractures, although the important caveat with this literature base is that it did not directly address patients with chest wall injury. So to conclude, the bottom line is that with all 4 clinical questions, there is a dearth of research into this topic in the chest wall literature. Established and existing perioperative guidelines to inform decisions about antibiotic choice, route, and duration appear to be adequate for patients without concomitant infection. However, for patients with concomitant infections, the antibiotic route, duration, and choice should ideally be based on the best practice for the concomitant infection and not depend on the presence of surgical stabilization. Now, with that, I would like to sincerely thank all of my co-authors in CWIS and SIS for all of the hard work that they put into this manuscript. These recommendation documents are a heavy lift, and I am privileged to be able to present our work product on behalf of my talented and exceptional co-authors. Now, for reference, I've included all of the documents included here, but again, I would encourage people to check out the June surgical infections manuscript where this manuscript will be highlighted. And with that, I'd be happy to take any questions.
Mike Wagner. I didn't see, did you compare these same questions to the orthopedic literature? Because essentially we're working with the same material that they're working with.
Yeah, so for our clinical questions, essentially number 3 and number 4, for the narrative review portion, we included a lot of the essentially open fracture data from the orthopedic literature and brought that in. Yeah, thank you.
Hey, Fred Pieracci, Denver. Joe, that was awesome. It was a pleasure to be part of that group. And I understand that what we were trying to do here is to provide antibiotic guidance for people who find themselves in unfortunate situations like I'm doing an SSRF with MRSA bacteremia or empyema. But we didn't really address, should we be doing SSRF in a patient with MSRA bacteremia or empyema? So what are your thoughts on that?
Yeah, great question. I think there's a lot of reticence to provide those recommendations in the absence of any data. I think all of us in this room who perform this surgery have a lot of concerns going into an operation with a patient with an active infection, such as an empyema, and thinking about throwing down a bunch of titanium plates. And the reality is, though, some of us are faced with that. I think really the next step in this body of research is to prospectively evaluate in a collaborative forum such as the CWIS Collaborative Center group how we manage these infections, because I think that will then inform the decision about should we or should we not be. I think it would be almost impossible to randomize patients in that setting, but if we understand what the long-term outcomes are of people who are plated with these infections in place, I think we as practitioners and clinicians can then adequately explain the risks and benefits to the patients and their families, and I think come up with at least some sort of societal recommendations for should we be doing this.
Hi, good morning. Carrie Valdez from Columbus, Ohio. Do you think there's any benefit to prevention with either antibiotic-infused washouts of the thoracic space or the subcutaneous space, or sprinkling some antibiotic-infused powders on the way out the door?
Great question. That has been addressed in the orthopedic literature as well as the guidelines from IDSA and CDC. And as far as the literature base currently exists, there's not. So while I think it is tempting to implement those practices because it will make you feel better in the short term, the reality is that amongst when large groups of patients, at least at the population level, there doesn't appear to be any benefit of that. But I would direct you to the CDC and IDSA recommendations, who actually very eloquently describe why they recommended what they did.
Okay, Dr. Forrester, thank you very much. That was amazing. If there's no other questions, I guess we're still running ahead of schedule, Dr. White.